Hello, I'm Andrew Foote. I'm one of the new emergency medicine consultants at Walsall Manor Hospital, and I'm going to take this opportunity today to talk about our new chest pain pathway that we've introduced into the emergency department. So in light of traditional teaching, it's all been cancelled because of COVID, I thought I'd make this video just to run through how the new chest pain pathway works. So this pathway has been agreed by cardiology, medicine, and biochemistry in the emergency department. And there's really four aims that it's trying to do. Number one, we're trying to reduce the amount of troponin testing we're doing on inappropriate patients. Second of all, we want to speed up our troponin testing. And now we're going to be using a 0 and 1 hour pathway. And wherever possible, we're going to rule out patients on a single troponin. And number three, probably the most importantly, we're going to try and use same day emergency care and get patients cardiology reviews on the same day wherever possible when it's needed. And lastly, we're going to speed up how quickly we can send troponins to the labs and get the results back. So before we go any further into the specifics of this chest pain pathway, I think it's important to note that this pathway is developed using the Troponin T biomarker by Roche. Now there's lots of different troponins used in the UK, so it's important to clarify if you're in a different hospital which one that your labs use, because they all have different cut-off values. So the background behind this pathway is that it's essentially using the European Cardiology Society's 0 and 1 hour chest pain pathway, which has been around since 2015 and has a lot of data around it. There's also been recent developments behind using a single troponin at the limit of detection, i.e. less than 5 nanograms, as a way of ruling out patients as well, providing they've got a normal ECG. And that data was from the LOADED trial, which was done in the UK here in 2019. So the benefits behind this is that, number one, potentially we can rule out patients with a single troponin, providing it's low enough and they're otherwise well with a normal ECG. Second of all, when we need to do a second troponin test, it's done at 1 hour, not at 3 hours. Again, so that's going to rapidly improve the time to either ruling in or ruling out patients in the emergency department. When we compare the two troponin results, which is important, and I'll get onto it later, we're going to measure the actual change between the two troponins rather than the complicated percentage change that was previously suggested in previous chest pain pathways. And lastly, we don't use risk assessment tools in our initial workup, because when we use risk assessment tools, we exclude a huge proportion of patients who come to our emergency department who we just have to admit if we use them, whereas this algorithm doesn't use those, so this can apply to all patients who come into the emergency department. So quickly looking at the numbers where this should apply to. Essentially, in our emergency department or the AEC, we should be able to rule out 60 to 65% of patients using a 0 and 1 hour algorithm. And we should be able to rule in about 15%. The remaining 20 to 25% of patients are going to be needing further workup, and that's what we're going to get onto later on. Okay, so let's have a walk through the algorithm and see how it works. So first of all, I think the most important thing to say here is this algorithm is for patients with suspected cardiac chest pain. And it's important to put the right people into this algorithm. I'm going to talk about this at the end of the video, about why exactly that's so important. So you've got someone, they've come in with cardiac chest pain. First of all, they're going to get triaged, they're getting an ECG, and it's also important when you first see these patients to look at their paramedic notes as well, and to look at those ECGs. There's been a lot of MIs that I've seen over the time which have been missed because people have not looked at the paramedic ECGs. And you can access this through our safe triage system if they've not been printed in the notes. So why is it so important to look at the paramedic ECGs? Well, a lot of the time people have had their pain while they've been with the paramedics. So if you're going to see ischemic changes, it's going to be while they had symptoms, i.e. when the paramedic took the ECG, not when you're seeing the patient when they're comfortable and pain-free in the emergency department. So look at those ECGs, please, and document them in the notes. So at this point, we've come up with criteria where patients may actually access an alternative service. So number one, the Urgent Treatment Centre, the UTC. If patients are pain-free, they're less than 40 years old, they've got no cardiac risk factors, and they've got a normal ECG, they can go to the Urgent Treatment Centre if we're not suspecting a heart attack. Second of all, people can go to our ambulatory unit, the AEC, if they're pain-free, and this is really important. Please don't send people to the AEC if they still have pain. So if they're pain-free and they've got a normal ECG, they can go to the AEC, providing they've got normal observations. And they'll continue using this same pathway, but in the AEC. So the rest of this pathway, it doesn't matter whether you're in the AEC or the A&E, you're still going to do the same thing for your patients. So let's have a walk through. So quickly, let's talk about the unstable patients. Nothing much has changed here, but just to clarify exactly what you do. People who have dynamic ECG changes, they've got ST elevation, or they've got a new left bundle branch block. These patients need discussed with our heart attack centre, which is in New Cross. So the way to do that, there's a page on the algorithm about this, but what we do is we email over the ECGs, and the receptionist and the A&E can help you with this. Please don't use faxing anymore. That technology is way out of date, and the Heart Attack Centre wants us to use their email address, so please do that. So email the ECGs for the paramedic ECGs and our ECGs from the emergency department, labelled across to the Heart Attack Centre, then phone up the cardiac nurse, and again the number's on the pathway here, so please use it, and they will discuss the patient with you and arrange urgent blue light transfer, which the nurse in charge of the emergency department will help you with. It's important to let the senior doctor in charge know about these patients, because we need to move quickly with these patients. If there's any problems with transferring patients, the cardiologists on call are available to offer some advice or assistance in referral if needed. The next group of patients to talk about are the patients who have either ongoing chest pain, ECG changes in keeping with ischemia, or they've got a history suggestive of unstable angina, i.e. patients who have rapidly deteriorating symptoms or very frequent symptoms. They need admissions under the acute medics, regardless of the rest of this pathway. So, with those caveats aside, and those high-risk patients either transferred to another hospital or are directly admitted under the medics, the rest of the patients are going to have a 0-hour troponin done. And that 0-hour troponin is the troponin that is sent when the patient arrives. Regardless of the time that started, the 0-hour troponin is when they arrived at our emergency department. So when you get the first troponin result back, if it's less than 5 nanograms, these patients are at incredibly low risk. This is less than the limit of detection for a troponin. So these people, if they're pain-free and they've got a non-ischemic ECG, they can be considered for discharge. Now, as part of our emergency medicine standards, all patients with suspected cardiac chest pain need reviewed or at least discussed with a senior doctor before they go home. So please make sure you do that and document it in the notes. We need to consider the alternative causes for chest pain, because let's face it, if they've got troponin less than 5, it's not going to be cardiac. So that needs considered. Now, if you really think these people have underlying heart disease, and it's very unlikely, they can be followed up in our chest pain clinic, and I'll come on later in the video to discuss exactly how that's done. But that shouldn't be the usual pathway for these people. Now, if the troponin's still within the normal range, i.e. up to 12, but it's more than the limit of detection, these people, they've still got normal troponin, but it needs repeated at an hour. So make sure when you've sent the first troponin, you document when the second one's due so that we can do that. Now, the third group of patients, they may have a mildly elevated troponin, i.e. less than 52, but more than 12. Again, these people, they've got a raised troponin, but now we need to decide whether it's a dynamically raised troponin, because they're the people who are going to be having potentially a non-STEMI. So lastly, the people with a troponin over 52. Now, over 52 makes a diagnosis of an acute MI much more likely. It's not a definite rule-in, but these people are clearly at much higher risk and they need to come in under the acute medics. And if their history is suggestive of a heart attack, please start them on the ACS medications as well. So now, everyone except from the group you've already excluded, i.e. those people who had a troponin less than 5, the rest of the patients need to have a troponin repeated at an hour. Now, that's a minimum of an hour, so it can be repeated after an hour, just not before. So once we've got the 1 hour troponin result back, what we need to do is compare it to the 0-hour level. And what we're looking for is a change between the two troponin values, because to diagnose a heart attack, you've got to have two things. Number one, you've got to have a rise and fall of troponin levels. And secondly, one level has to be above 12. And that rise and fall we call a delta change. So when we look at the change, if there's a less than 3 change between the two levels, we call that a static change. And those patients, they're not having an acute MI. If both levels are below 12, send them home. With the same advice as before, so we're going to think about alternative causes for their chest pain, and we're going to get them reviewed by a senior doctor. And if appropriate, if their symptoms sound anginal, they can be reviewed in our cardiac chest pain clinic. Now, second of all, if there's a mild change between the two troponins, i.e. between 3 and 5, or they've got one of the levels which is above 12 but less than 52, those people are in our observation zone. We can't either rule in or rule out a heart attack at these points. Now, it's important to take this group seriously. Up to a third of these people will have an underlying cardiac problem. So these people do need further workup. And I'm going to get into that in a minute, into exactly what we're going to do. And lastly, we're going to get the people who have clearly ruled in at this point. Either they've got a level which is more than 52, or they've got a dynamic rise. So those people have a rise of more than 5 from the first one to the second one. And it can be a rise or a fall, and that's important to remember. So those people, they get treated with the ACS medications, and they get admitted under the medical team. So the observational group. So these people need more workup because, as I previously mentioned, up to a third of these patients will have underlying cardiac disease. So it's important for us to do more investigation in this group. So if they're stable, they can go round to the ambulatory unit, our AEC, for further workup. And what we're going to do is we're going to do a troponin at 3 hours, i.e. 3 hours after the 0 hour sample, to see whether these patients will rule in at this point for an acute MI. So when we get the 3 hour sample back, we're going to do the same things as we did with the 1 hour sample. Have they got a static change in their troponin, i.e. less than 5 between the two, or have they got an increased level of their troponin, or a decreased level, so a more than 5 nanogram change. So if they rule in at this point, that's fine, admit them under the medical team. If they've ruled out at this point, this is where clinical judgment's going to come in. So these people tend to have had a minimally raised troponin level. So the key question you've got to ask is, do you think this is due to underlying cardiac disease, or do you think this is just chronically elevated? So there can be lots of causes for chronically raised troponins. It can be down to advanced age, hypertension, heart failure, renal problems. So they're all chronic causes which can cause people to have just mildly raised troponin levels. And in general, an admission into hospital is not going to be beneficial for these patients, and they can go home and they can be followed up by their GP if required. Now, there's another group of patients who are actually going to be acutely unwell with their mild troponin rise. Now, it's important to think about other causes for troponins in these patients, so pulmonary embolisms, acute aortic dissections, things like that sepsis, they can all cause mild troponin rises as well. So it's important, if they're unwell, these patients need admitted under the AMU. And hopefully, those patients wouldn't have come round to the AEC in the first place because they'd have been unwell. And lastly, some of these patients are going to need a further cardiology investigations if their history is suggestive of cardiac disease. Now, to do that, we need to decide how urgently they need their cardiology review. And to do this, we're going to use the heart score. Now, the heart score has been developed in the emergency department, and it uses information that's readily available to us. So what's the history like? Is it suggestive of cardiac disease? What's the ECG like? Is it ischemic? What's their troponin results, and what are their cardiac risk factors? Now, if their score is 3 or less, they can be followed up as an outpatient, and I'm going to tell you how to do that in a moment. And if their score's 4 or more, discuss with cardiology on the day. Now, cardiology are fully supportive of the AEC. They will come down and they will review these patients during the day. And from there, they'll work up a cardiology plan of what they want to do with these patients. And most of the time, they can be investigated as an outpatient because they have ruled out for a heart attack at this point. So they don't need to stay in hospital. And that's the great thing about this new pathway, is that patients who are traditionally being admitted into hospital, they can now be seen as an outpatient with a clear plan in place. Now, the people who are lower risk, heart score 3 or less, they've got about a 1% chance of having a further event at 60 days. And they're going to be seen in our cardiology clinic over the next couple of weeks. So booking cardiology follow-up appointments for our low-risk patients. So they're going to be one of 3 groups. Either they've got troponin less than 5 and they've ruled out immediately. Generally, these people do not need followed up, and it's unlikely they've got underlying cardiac disease. Because if you've got a troponin less than 5, not only have you ruled out for a heart attack, it generally says you've got a very healthy cardiovascular system as well. So unless these people really have a history which is highly suggestive of ischemia, they don't need followed up. But if they do, by all means get them followed up. And the same is with the patients who've had 2 troponins less than 12 as well, with no significant change. Again, you can get these people followed up if their history is really suggestive of heart problems. Now, if they've got a troponin which is mildly elevated, again, these patients generally do need followed up if you think they have underlying ischemic heart disease. So what you do is you log on to Fusion, you select electronic patient handover, you select the patient, and then you select cardiology. Now, cardiology will review these referrals and get every patient followed up. So just write in the details of why you want them followed up and what the story was. What I'd ask though is that can you please make sure any ECGs or any notes that you have are available for the cardiologist to review, and that generally means getting one of the receptionists to scan them on the system. Because it's really important when they see these patients in clinic, they have access to all the information that we had in the emergency department. So when it comes to actual troponin testing in the emergency department, when we're requesting the troponin tests under the ICE requesting system, what you'll find is under the A&E tab, you'll see a 0, 1 and 3-hour option for troponin testing. And they're designed so that, number one, we know which troponin we're looking at when we go through and interpret it. But secondly, the labs have said they're going to run these tests quicker than normal for us. So that means that we can rule in and rule out patients much quicker than we could normally. So the last thing I want to talk about is sending troponin testing in the right patients. So we've done a lot of work with developing our triage protocols for taking bloods. So by all means, use the troponin testing for ruling out cardiac chest pain. That's what it's there for. But where I find it's unhelpful is sending troponins in patients who have had fast AF without significant cardiac chest pain, patients who've got SVTs or syncope without chest pain or ECG changes. Those patients, even if they do have mildly elevated troponins, generally the answer is treat the underlying cause. So if they had fast AF, treat the fast AF. By sending these troponin testing, what tends to happen is these patients get further testing, they get inappropriately admitted into hospital, and we know there's real harms with admitting patients into hospital, particularly in the COVID era. And secondly, it means that a lot of these patients actually get put on ACS medications inappropriately, and we know there's a 4% chance of major bleeding associated with our ACS medication. So really think, before you send that test, think what's going to happen to the patient later down the line. So there we have it. That is our new chest pain pathway for the emergency department. So the main aims here is to speed up our troponin testing, reduce the amount of inappropriate troponin testing that we're taking, and of course to utilise same-day emergency care wherever possible to try and keep as many patients out of hospital as possible and give them the appropriate cardiology follow-up.